next question and answer participant here is Dr. Michael Basso. He is really one of the world's leading experts on neurocognitive disorders associated with demyelinating disease, like many of his studies have been in multiple sclerosis, but now most recently he's looking into the neurocognitive aspects of MOGAD and some of the other autoimmune conditions of the brain. And he's been a real asset to us to have at Mayo Clinic. Many of the people in the audience may have seen him. He really evaluates thoroughly all of the cognitive aspects of MOGAD. So he'll be available for all of the questions as a neuropsychologist. So thanks, Mike.
Well, thank you. Thank you very much for the very kind and generous introduction. I suspect that in many ways, my time up here might be one of the shortest moments of this entire conference, because in terms of cognition and this disease, it's there's not really a lot of I think, to my way of looking at it, confident conclusions that can be made about the nature of cognitive function. Most recently, I've done a review of the literature, and I think I found about 20 papers that have looked at cognitive function, and probably most of them are dealing with children. And of the few that are dealing with adults, there's probably about 2 or 3 studies that I think have reasonable quality. But the tricky part about this research is that most of the studies are based on case studies where there's maybe 1 or 2 people that have been evaluated, or they're based on really, really small samples of people, maybe 15 people. And it's not entirely clear were these people referred because they were for testing because they had cognitive concerns, or was it that it was just a broad sample of people who had presented to clinic who were just routinely seen in series, because there's potential biases that might result as a result of if they were all folks that were referred because they had cognitive concerns. It was really interesting to hear the folks up here earlier this morning talking about their experiences of cognitive challenges associated with this. What I can tell you is with not a lot of confidence, there's a research base that shows that folks are apt to have some slowed speed of information processing. They have to hear things repeatedly before the information sticks. They're apt to have some challenges making solving problems and planning, problem solving, and prioritizing things, and they're apt to having some memory problems. And there's some reasonable evidence that the folks who are most likely to have those problems are the folks that had more of the encephalopathy presentation when they had their initial attacks. And in terms of the long-term follow-up with this process, there's not a really, I found one longitudinal study looking at this, and it was pretty encouraging. It showed that actually after a year and 2 years out from an initial evaluation, that the cognitive problems for most of these folks had really gone away, which is very encouraging. I think the thing that doesn't give me a lot of confidence about those kinds of findings is that it's based on very, very small samples of people, and in terms of how the people were characterized, it wasn't really clear as far as were these the folks that had sort of the lesions that were in the thinking parts of the brain, not just vision and not spinal cord and not necessarily cerebellar, so the movement problems, but in terms of the cortical and thalamic and white matter lesions. So there's a lot that we really don't know about just what are the factors that predict cognitive impairment in folks that are presenting with MOG, and also what are the long-term consequences of treatment and relief from all of the neurologic symptoms. So it's certainly a very fertile field for research to be conducted, and I think there's a lot of difficulties with being able to provide good answers to these questions simply because it's such a rare illness, and getting a good number of people who are presenting with this condition to undergo some kind of cognitive testing, that's a challenge in and of itself. So, but I'm probably raising more questions and confusion for you than I would have liked to. But unfortunately, that's kind of my take on the status of this research. And I tend to be a very conservative consumer of research. I'm somebody that I want to see conclusive findings demonstrated repeatedly across multiple studies before I'm willing to say, oh yeah, this means something. And unfortunately, I think the nature of the research is, if we've only been looking at this as a diagnostic entity for about 18 years, it's probably not surprising that there's not an awful lot of research, especially because most patients present primarily with non-cognitive presentations, the optic problems, and the movement problems. So I suspect that this is something that is probably going to be increasingly recognized as a concern that we, as a profession, need to really take a much more in-depth assessment of this problem. And so with that, I don't really have any other comments to make, but I'll be happy to try to answer questions as best as I can. Please.
Hello, Andrea Mitchell, MOG Project. So a little over 2 years ago, I had a severe brain relapse, and it affected my frontal lobe. And they're giving me speech therapy to try to help me repair my memory, but it's just not getting better. It's getting worse. So the other forms of things that I use to try to help with the memory is the Simon game with the color matching, and the Bop It where you twist, pull, punch the guy, whatever.
No, I love those games. They're great.
Is there anything else you could recommend to help repair the cognitive and memory loss?
And again, the research isn't there to talk about what is the long-term consequences, especially among folks who have acquired some meaningful cognitive changes as a result of this illness. We don't know, because research hasn't been done. My sense is that you're receiving speech therapy because normally, in terms of cognitive rehabilitation, speech pathologists are the folks that really own that responsibility. And they're probably about as effective as they can be, simply because they're teaching you ways of accommodating and working around your existing problems. And without having, I don't want to get into the weeds of what your specific problems are, but it would be worthwhile to be patient with the process, simply because nothing works quickly, and everything works in small increments. And in many ways, I think that the cognitive rehabilitation doesn't eliminate the underlying problem, but it teaches you ways of working around it and coming up with compensatory and adaptive strategies. It may not make it a return back to where you were before you got sick, but it may make it so that it's not as bad as it is without those strategies. And unfortunately, I think that, like I said, without knowing what are the long-term outcomes, I can't really give you an answer to your question, other than to say, I don't know, but the cognitive rehabilitation strategies are probably about as good as it's going to get.
Thank you.
Sure. All right.
Yeah, we have one from the chat, so I'm just gonna get on the microphone. Even though I'm really loud, I'm a teacher, so okay. All right, hi everyone. So this is from Eleanor, which I also find this question interesting. Slow processing speed and challenges solving problems can just describe a normal child. It feels impossible to identify what's a symptom and what's a kid being a kid. Any tricks for parents or caregivers whose MOG kids struggle with brain lesions, but not physical impairments that would be more obvious. How do you parse out the normal growing and changing kid from MOGAD symptoms?
Well, you're asking a neuropsychologist a question that the neuropsychologist will say, have your kid undergo an evaluation, to nail down the specifics. If your child is struggling in school, and if the school has taken notice of those problems, typically, if you are a very, very squeaky wheel, you can oftentimes, well, I shouldn't say oftentimes, you can sometimes get the school to conduct some kind of a formal evaluation of your child's cognitive ability as well as academic skills, so that they can identify whether or not your child merits special intervention, an accommodation plan, or an actual individualized educational plan. And depending on who is providing services to your child, my guess is that most tertiary care facilities, that are providing services like this to children, will have pediatric neuropsychologists that could also conduct that kind of an evaluation. So either going through the school, if the school is also recognizing that there's some problems, or going back to your neurology treatment team to request a referral to a pediatric neuropsychologist to try to obtain some kind of clarity about whether or not this is a normal developmental trajectory for your child, or if there's been some kind of acquired cognitive challenges as associated with MOG. Please.
So for someone trying to establish a cognitive baseline for themselves when they're not having an episode, is there like a specific cognitive test that's used for that, or that you'd recommend?
Yeah, I'm a bit cynical about things that you see online. I mean, you've probably seen this if you've wandered on the internet at all over the last 15 years. Things like, if you can answer this question, you have an IQ of 160. And the kind of cognitive tests that are available online, they're not. I don't think that many of them are trustworthy. And so if you have concerns and you're worried that maybe there's some changes afoot, again, I would consult with your treatment provider and request a referral. But in terms of if you're not noticing any problems, oftentimes the neurology team will have screening instruments that they'll administer. So locally here, there's a tool that was developed by one of the neurologists on staff, and it's the short test of mental status. It's named after the locally we kind of refer to it as the Kochman, because it was Dr. Kochman that originated this. It's a nice tool. I think that in many ways it has some shortcomings for folks with these kind of demyelinating illnesses, because the problems that tend to appear in conditions such as MOG, they're not really sensitive to that kind of a mental status screener. And so I'm giving you a very long-winded non-answer, and I apologize for that. But the short answer would be, I don't really have a good answer for you other than undergoing some kind of an evaluation. One of the things that we're trying to incorporate here, and it is, and I need to check back with the research staff in the autoimmune research clinic, but there's a computerized measurement device that I think we've started collecting data on, with it just blanketing everybody that comes into the autoimmune clinic, so that we can establish a baseline neuropsychological status on them. It's something called the automated neuropsychological assessment metric. If anybody here, everybody looks like they're about my age, but if anybody here has been in the military in the last 20 years, you had to undergo this computerized testing battery before you deployed. It's the Department of Defense's mandated neuropsychological screening device, and it's a pretty decent tool, and I like it. So one of the things that we're hoping to do is establish not only how people are doing cross-sectionally, but also to be able to follow them longitudinally over time, so that we can establish what things are taking place, if any. Is there any changes? With that kind of a device, it's much more in-depth than these mental status screeners, and they're also much more dependent upon speed of information processing. And the only shortcoming with a condition such as MOG, though, is that it's visual. And so I suspect that in many ways that might be at odds, at a cross currents with folks that are having optic neuritis and some of the residual problems associated with those attacks. But it's right now that's sort of our initial baby step towards trying to establish and address those kinds of issues that you're raising here.
You could have your neurologist give you a referral to see a neuropsychiatric licensed doctor. And if you're visually impaired, they will read a story to you and see how much of the story you remembered, or words, or letters, or numbers, etc.
Did they? Oh, I think she heard you. Did everybody hear that? Yep. Okay. Thank you, Andrea. Thank you. We have time for one more question.
This gentleman back there has got a question.
Oh, okay.
Do the cognitive impacts of MOGAD show up differently than dementia or Alzheimer's?
You know, nobody's done a direct comparison like that. The closest I've seen is a study comparing MOGAD to folks with MS. And you know, in terms of comparing people with MS to folks with Alzheimer's, as a matter of fact, that's something that hasn't really been done. Dr. Keegan, who's also in the autoimmune group, who I don't think is here today, he's doing some work with the behavioral neurology folks to try to distinguish among older people with MS from Alzheimer's. But it's as a matter of fact, he just sent me the manuscript that he's written yesterday, so I'm going to be reading that over the next couple of days. So that's again a long-winded answer to say I don't know. There's not really there's nothing out there based on clinical experience and clinical judgment, not empirical data, not published research. My sense is that in Alzheimer's, for example, there's a much greater prevalence of cortical findings, meaning that the person is more likely to have some very, very salient memory impairment. They're also more likely to have some much more salient presentation of sort of reasoning and concept formation, problem solving, and difficulties. With these demyelinating illnesses, more often than not, the most salient key deficit or problem is an information processing speed issue and an attention and concentration and working memory problem. Folks with these and it makes sense, right? Because if you think about the brain, the white matter it's sort of the connective tissue. It's the wiring from one neural processing center to another. And if I'm like eroding the insulation on copper wire, the signal, the electrical signal that's going through is going to be a little bit slower, a little bit less efficient. And same thing with your brain. The ability of different neural centers being able to talk with each other is going to be degraded and slowed. And so many people consider that to be the principal deficit associated with these demyelinating illnesses like that. My sense also in terms of memory difficulties is we don't really know what the nature of memory impairment is in MOG. From MS, which is kind of similar in some ways, memory impairment is different from that which is seen in Alzheimer's. And so you can potentially do a distinction between those groups as well. But again, this is, before I came to Mayo, I was a college professor for about 25 years, and there's a very straightforward bit of advice that I can give all of you. If you want a quick and clear and precise answer, don't ask an academic, because they're going to tell you way more stuff than you ever want to know. So, but the quick answer is we don't know, but the long answer is what I've just kind of meandered for you. All right, well, thank you very much.